Good morning, everyone, and welcome to the Indiana Hospital Association Sepsis Across the Continuum Focus on Prevention webinar today. My name is Rebecca Hancock, and I'm in the room here with Casey Hutchins, our Communications Director for our Patient Safety Center. We look forward to featuring IU Health, University Hospital, and Clark Memorial Hospital today on our webinar. As per usual, you can navigate your webinar here by opening up the chat. If you move your cursor to the top or bottom, a black bar will open and you can click chat or more to get to the chat room, and you can input your name and your hospital name, if you would please, so we have a record of who all has attended. And if you would also put your phones on mute while we're doing the webinar until the very end when we open things up for discussion. Our mission here at the Indiana Hospital Association has three main goals: prevent patient harm, improve community health, increase patient and family engagement, and lead a culture of safety. On the left side, I talked about this in the last webinar, is a geographical map of Indiana and which counties fall into which coalitions that we lead across the state. We have 11 different patient safety coalitions. We're leading that throughout the state. Each of us on the Patient Safety Center team heads up one of those with leadership from the hospitals to drive performance improvement and hospital care across the state. Today, our objectives for the sepsis prevention webinar is we'd like for you to be able to describe Indiana Hospital sepsis mortality and bundle compliance improvements, and in turn, be able to relate that to what your own data shows. Identify strategies for sepsis prevention, and we've got two main ones that we're going to highlight today, but several others will be mentioned, and describe the hospital and community outreach initiatives for improvements and prevention in sepsis care that you may be able to initiate. This is the fourth in our series of webinars. Our first one was on sepsis bundle compliance, then screening, then post-op sepsis syndrome, post-sepsis syndrome and readmissions, and lastly, prevention. Each one of these is recorded and available on our www.survivesepsis.com website. I also want to mention at this point, I thank you tremendously for your sepsis survey responses that each of the hospitals did. We have 88 responses, and I'm excited to get in and start analyzing that data. I will provide a little bit at the end of this webinar, just a touch of it, but I'm especially thankful for all your comments about what you've been successful with and what are your challenges so that we can develop our programming for the rest of this year and next year. That's done in coordination with the State Department of Health State Sepsis Task Force, and we also have an upcoming meeting to review what we're going to do for our hospital submission of data and recommendations based on the sepsis survey coming up. In the three webinars thus far, we had a call to action at the end of each one. When we talked about bundle compliance, I asked you to view Dr. Kaiser from Columbus and Casey Barnett's from Terre Haute Regional's podcast that we have on survivesepsis.com. That was done during September, but you may have missed it. They highlight many strategies for bundle improvement, and that's an area that we know will reduce mortality in all the hospitals. We ask you to plan a community education event, as was done in September, and develop a plan to improve your own sepsis bundle compliance. If you are below the state average, the national average of 58%, we ask you to set that as your goal. If you are above the state average of 58%, we ask you to target the top decile of 80%. So there's where your goals are that we've set internally here, and we look forward to seeing your strategies in the future. Our second one is on sepsis screening. The call to action was to assess your emergency department and inpatient areas for sepsis screening and rapid treatment processes. What are your areas of opportunity and what are your areas of successes thus far, and what do you need in order to improve that? A lot of opportunities and resources were shared in the sepsis survey that we did, and we'll be able to share those at a future time. Again, ask you to plan a community education event to reduce time to treatment. What we know is that in the screening process, if we get the patients to the emergency room faster with their symptoms, within reason, then we can actually reduce the mortality by getting a more timely treatment. And Judy Brom is going to go straight into that today, and I think you'll love what she has to say. Lastly, educate the hospital staff to be leaders in sepsis awareness. That's all hospital staff. The reason for this is that we are all a part of a big social group, and it has linked lives at the heart of it. Everyone is linked with someone else, and if you happen to talk to someone who's more aware of sepsis than you would have prior to the knowledge that we share, it's an improvement in care, and we are at 65% in the nation for sepsis awareness based on Sepsis Alliance's data. I don't have specific Indiana data, but we look forward to everyone understanding, to the extent that they understand acute MI and stroke care and signs and symptoms. Lastly, last month, post-op sepsis syndrome and readmissions, we asked you to identify your highest DRGs for readmissions and address the sepsis needs in those DRGs. We know that Indiana is the #1 discharge diagnosis in Indiana is for readmissions is sepsis. Secondly, specify your sepsis discharge information for patients and families and identify their needed rehabilitation. We need to improve upon our sepsis discharge information, and I got that loud and clear in the survey responses, and so we will work on that. But also I appreciate some of the shared resources that are available through Sepsis Alliance and the CDC. Let's talk about data just for a moment. I apologize for hustling here. I want to make sure we get to all of our sharing of our specialty clinical specialists who are going to speak. What do we know about our sepsis data? We had for our HIN a target of 20% reduction in 3 metrics: overall sepsis mortality, hospital onset sepsis mortality, and post-op sepsis rate, which is the ARC PSI 13 and a part of value-based purchasing. Our sepsis mortality is on our next slide, but right here I want to mention that hospital onset sepsis mortality is right now 16% worse than it was in our 2015 baseline. And that's based on in-hospital deaths per 1,000 discharges, ages 18 to 89, including OB. So it's a little bit different, slightly different than the CMS metrics because it includes OB. However, what I believe is that there's more screening going on. There's a lot of electronic health record screening going on out there, and so we're identifying more sepsis in the inpatients. So hospital onset sepsis mortality, we've worked very hard on our ED processes, and as we improve inpatient care for hospital onset sepsis mortality, I expect this to go down, as we're seeing in the last 3 months of this data monitoring period of July, August, and September. As you can see there on the left graph, it looks better in the last 3 months. Secondly, our post-op sepsis rate of incidence of post-op sepsis per 1,000 surgeries is at a 1% improvement compared to our 2015 baseline. A lot of variation there, not really driving improvements. A few more under the target of 20% improvement that's on the graph on the right in the last few months, but this is an opportunity, and this is where we want to work on inpatient bundle compliance and prevention. So you'll hear some of our content today around prevention of inpatient pneumonia and therefore inpatient sepsis. On our bundle compliance, this is retrieved. They just did an update in Hospital Compare, and what it shows is that we are currently at 55% in our state based on a 1-year period of second quarter 2018 to first quarter of 2019. This was updated around the 29th, maybe the 28th of January. We are 3 points off the national average. Let's go, let's do it. Just do it. Our top decile for all the hospitals is currently at 80%. 80%. So we're going for that, but as I mentioned it previously, a goal is if you're not at the national average of 58, make that your goal, and if you're above that, make the top decile your goal. We've gone from, we are closing the gap on the nation. Let's do it. I think just if we keep moving forward and keep improving our process, I know that we can make this line cross. I mentioned the 2 stats on post-op sepsis and hospital onset sepsis mortality. And just to mention that hospital onset sepsis mortality has all the sepsis code with present on admission identified as no, not present on admission in the coding process. Now here we have our APR-DRG septicemia mortality rates. This is from DataLink. I've mentioned in all the webinars that DataLink is the IHA repository for all of your coded data. And we have available 4 different modules in there: ARC, value-based purchasing, ARC indicators, value-based purchasing, sepsis, mortality, and readmissions. So this is a little bit of data on sepsis mortality. We have seen a progressive decline from that APR-DRG 720 from first quarter 2014 to third quarter 2019 with a 44% decrease in sepsis mortality within this DRG if you include palliative. If you exclude palliative, it's a 56% decrease during this time period. As you can tell, we're nicely moving it down. Let's keep it up and keep identifying those bundle elements for improvement, and also considering within the guidelines it mentions to make sure that you're assessing the need for palliative care in the sepsis process. If we break it down and look at it a different way for the SEP1 population, which is defined as any primary or secondary DRG, so these are about 60% of the patients, sometimes 90%, depending on the location, will fall into your APR DRG, that it was present on admission and that's the primary cause. Those are the easier ones to treat because you've got it identified from the get-go. These sepsis SEP1 population who may have had not a primary sepsis DRG is a larger population of patients, but we are making progress, but we're not making it the rate as quickly as those who have a primary DRG of sepsis. However, from first quarter 2016 to third quarter 2019, and that's the time period that we can do because we had ICD-10 during that time period, we've seen a 19% decrease in SEP1 mortality, sepsis 1 population mortality when you include palliative, and a 34% decrease when you exclude palliative patients. And I just want to mention that in the chat room, Casey is monitoring the chat as we continue. If you have questions, she'll probably nudge me and we'll address it as we go. So we're making progress. I'm very pleased with this. I want to see the bundle compliance go up in the same manner that our mortality rates are going down. A few resources that I want to point out related to prevention. This is from September. We have podcasts on our survivesepsis.com website where all of our information is shared. My Infection Becomes Sepsis with Lindsay Weaver on the top left is an excellent program that has podcast that identifies what you can talk to your patients about if they came in through the ED and they're being sent home pending. What kind of things do they need to get back for? Secondly, Karen Kennedy, A Daughter's Concerns and Transitions, discusses the transitions in care that occur between a hospital and extended care facility and how that ended up in a sepsis. There are many opportunities for prevention that are identified in that. I think that's a good patient family engagement picture. Lastly, on the right side, we have Pediatric Sepsis Recognition podcast by Dr. Brian Wagers. I'm not going to go into peds today, but just know that that's out there. Dr. Brian Wagers' podcast with sepsis recognition, and his compadre there at Riley, Dr. Tyler Arnold, did one on sepsis treatment if you need those podcast information for your pediatric populations. I used this slide several times. It was one that I developed during my education, and as we can see across this, respiratory is the #1 cause of sepsis in the all adult population of peds, but in the older adult, urinary infections become #1, and respiratory is second. So what we're going to do today is we're going to focus on those two areas. We're not ignoring abdominal, wound, or soft tissue issues. We need to be very aware of those, especially abdominal issues, sepsis, which comes with a significant amount of pain. But know that we're focused on UTIs and respiratory today because those are the most predominant sources of sepsis. We do know that 22% sources of sepsis are still unknown, and we need to work on getting a good clinical history and identifying potential sources for our patients. Adding life after sepsis and sepsis prevention. I've highlighted in red the things that I want to point out today. Hand hygiene, of course, we know impacts infection rates. That is the host and how you can improve your host response to infection. Mobility. Patients who are up and moving are more likely to have better immune systems based on their muscle mass that they develop, as well as an increased production of T cells, and that increased production of T cells can improve infection fighting. Hydration. Below, older adults, when they leave the hospital, will stop drinking just like they tend to do, and that can put them right back in the hospital with another infection. We need to have discussions about hydration. We've heard someone's glass that they carry around their drinking container is called a hydrator, and if we get people to think about that as a hydrator, I think that we will potentially get more fluids in our patients at discharge. Immunizations, we'll touch on that, and also oral hygiene is what IU Health is going to talk about. A recent article in 2018 by Kemper, Wang, and Martin was actually a part of the original sepsis guidelines, is sepsis is a preventable public health problem. There's primary, secondary, and tertiary approaches to sepsis prevention. We've talked about secondary prevention in our previous webinars. Tertiary prevention, limiting the consequences of sepsis. We did that in one of our webinars for post-sepsis syndrome. And today is primary prevention of infections and sepsis onset. Note that immunizations is listed, hygiene, public awareness, antibiotic prophylaxis, and managing the risk factors, several of which we'll touch on today. Here's the model that Kemper shared around tertiary, secondary, and primary prevention model. It leads us through the chain of events with sepsis and provides intervention at each point with which prevention can be done. To open up for Casey's presentation, I want to mention that in our 2018 webinar series, Joanne Brooks provided us with a non-ventilator hospital-acquired research update. That is available at survivesepsis.com at the bottom of that page under archived webinars, and it is the backdrop to what we're talking about today. If you Google Barbara Quinn and Diane Baker for any articles that they've done, it's all around non-ventilator hospital-acquired pneumonia. So I talked about the hospital onset sepsis cases in the data, and many of those are pneumonia, and I'll show a little more data on that in a minute. But pneumonia is the #1 hospital-acquired infection according to the CDC, 15 to 31% death rate associated with hospital-acquired pneumonia. But they did began their research in 2014, and this is a 2017 Wall Street Journal article where Wall Street Journal picked it up that they were brushing their teeth several times per day. They got the patients to do that, and they cut their hospital pneumonias by 70% with a 50,000 toothbrush expenditure. Where is our nursing care in doing oral hygiene? We need to get back to basics. In January 2020, they published this article that using HCAP data from 2012, and they used ICD-9 codes of pneumonia and sepsis. What they found was that 36% of the patients who developed non-ventilator hospital-acquired pneumonia also developed sepsis. And of those patients, there was a 21% in-hospital mortality rate. 36% of patients who developed the in-hospital pneumonias also developed sepsis, non-ventilator. We've done a great focus on ventilator-associated events, but we need to pick it up on non-vent hospital-acquired pneumonia. Of those, 39% were discharged to healthcare facilities, whereas 84% came in, they were admitted from non-healthcare facilities, and only 57% were discharged to non-healthcare facilities. This is a very nice article by Giuliano and Baker. I'm not going to go into detail on this because obviously there's enough right in front of you there to read, but Casey very nicely created this slide which shows we've been working, the industry has been working on this since 2001. IHA started reporting in 2008 and has been doing a number of interventions since then, every year at least annually during our sepsis awareness, and we've picked it up within the last three years of a little more frequent sepsis programs by the HIN. And then the State Department of Health Task Force was formed. We also have hospital compare guidelines, hospital guidelines being produced, and Hospital Compare starting to publish adherence to the guidelines in 2018. Right now, we're at 65% Americans are aware of sepsis based on the Sepsis Alliance, and that's the same for the last 2 years. So let's get out there and make that a little better. Just brushing up on the symptoms of sepsis by which we can educate others. These are the subjective symptoms based on Sepsis Alliance that patients experience, which is a little different than the objective Sears criteria that we look at, but know that this is worth using. This is good information for our patients when we're doing community education. The Sears criteria. Some Sears criteria, which is the basis for identifying sepsis, include an altered mental state. Some do not. I think this altered mental state is very important for our older adults and may be our trigger to go, is there a new or suspected new or worsened infection? And so, of course, taking a look at the Sears criteria, is there a suspected new or worsening infection is the screening for sepsis. I wanted to throw in one example of a hospital's process tool by which they share and communicate on what is going on with their patients in order to meet the bundle and the timely application of each element of the bundle. There are several of these that are out there. Sepsis Society of Critical Care Medicine has several. I have several that have been shared with us through the sepsis state survey that we did, and that will become a library for us to use. I also have available chart discovery tools that HIN has provided, and there are several listed here, all the types of different chart review tools. You take 10 to 20 charts, you use these discovery tools and evaluate what steps are missing in your guideline process. You can go to the HIN website and find those, or I can provide those for you if you need. We also have sepsis present on admission checklist and sepsis onset after admission checklist that I have access to that I can share. The top two, post-op sepsis and readmissions, are available on the HIN website. These other two are in the pilot phase, but I'm willing to let you take a look at it and see if it's helpful. Now I want to introduce our two speakers. First of all, Judy Braum is going to talk about assessing and reducing your time to treatment. She will be our second speaker here. Casey Rouland will be our first speaker. But Judy Braum from Clark Memorial took our recommendation to do extended care facility education to the nth degree, and I'm so proud of her work down in her area in southern Indiana. Next, we're going to turn it over to Casey Rouland from IU Health Methodist on saving lives one mouth at a time. And Casey, I'm going to stop my sharing now so that you may begin your sharing of your slides. So if you click share and then click your slide in the background, you should be able to be the one with slides up. Excellent. Smooth work. Casey, can we hear you now? Be sure and unmute your phone.
Hello, this is Casey. Can you hear me?
I can hear you. Thank you, Casey. Please proceed.
Wonderful. Wonderful. Well, thank you for having me today. My name is Casey Rowan, and I am the Director for Multi-Specialty Surgery with IU Health at the Academic Health Center. At the time of this work, I was the unit manager for a 24-bed surgical oncology unit at University Hospital downtown. So throughout my presentation, you'll discover the emerging evidence which we've heard about already today, that shows a strong link between oral care and preventing non-ventilator associated hospital-acquired pneumonia. And you'll be able to hear how we executed an evidence-based program to bring oral care to our patients. So first, I just want to have a little fun. So we're going to play a little game. There will be no prizes, but if you feel like a winner, celebrate somehow today. So first question, hospital-acquired pneumonia and community-acquired pneumonia are usually caused by the same types of bacteria. So this is true or false. And if you said false, you are correct. So it is most often caused by organisms considered to the common upper airway, and nosocomial pneumonia is often caused by the gram-negative, so the gut bacteria. All right, next question for $200. The more teeth a patient has, the less likely they are to develop hospital-acquired pneumonia if they are MPO. And that answer is false. So the more teeth a patient has, the more likely they are to develop nosocomial pneumonia if they are MPO. And that is because the teeth harbor dental plaque that serves as a reservoir for biofilm, allowing the bacteria to flourish in these patients. Question for $300. Why are the elderly at increased risk for nosocomial pneumonia when in the hospital? And if you guessed all of the above, you are not correct. The correct answers are elderly people frequently aspirate during their sleep, their defense of their airway may be impaired, and they're more likely to have poor oral health because they will need help with eating, feeding, and mouth care. Next question, having an NG tube or oral tube feeding in place by itself increases someone's chance of developing pneumonia. And that answer is true. So the tube does allow for small quantities of gastric fluids to migrate, which can be aspirated, which can increase the risk for pneumonia. And then last question for $500. Cleaning dentures regularly would have no effect on the likelihood of developing pneumonia. And that is false. So dentures are actually a significant reservoir for microorganisms. So it is necessary to brush dentures to prevent aspiration. So appreciate you playing that game with us, and that is what we used with staff on the unit. So myself, Shelley Lancaster, who is my clinical nurse specialist, Audrey Glossinger was a unit educator, and Jessica Mendenhall was a shift coordinator. And we used that to kick off our work and to really engage staff to make this work fun. So the purpose of looking at non-ventilator hospital-acquired pneumonia, we know that right now there's no requirements to monitor, but that is going to be something that we will be reporting as we look at length of stay and cost of healthcare. It has an impact. It also, mortality can be as high as 50%. And it significantly increases discharge to skilled nursing facilities. So those patients who could potentially have gone home would actually end up having to go to a skilled nursing facility after discharge. So our reason for action, we had IRB approved research study that revealed our academic health center had the highest rate of non-ventilator HAPs within the study group at the hospital here. And also during my leadership rounds, I noticed that unless a patient was asking us to brush their teeth, we were not offering. It was not something that our support staff or nurses thought about as being an important piece to the patient's care. And then when I got into the documentation, we realized that 0% of the time we were documenting any sort of oral care on our patients in the electronic medical record. This floor has many NPO patients, so it's a pancreatic oncology floor and a colorectal oncology floor. So many of our patients were NPO for extended length of time. However, most could complete their own ADLs. So there was an assumption that if patients wanted to brush their teeth, they would ask, or they would go ahead and do it. So that was really the call to action for myself and our team. And so really how we changed the unit culture, we did it in a couple different ways. So the oral care Jeopardy game that you got to play, we did that for all team members. We would just see, hey, are you available for a quick game? We'd try to get a couple staff to participate all at one time, and we actually used toothbrushes and toothpaste as our prizes just to increase awareness. We really talked about Barbara Quinn's article about all of the work that she's done on non-ventilator hospital-acquired pneumonia. And we made sure to recognize staff who were routinely completing oral care and offering it to their patients through safety huddles and a unit newsletter. So we also created, through our professional practice council on the unit, oral care standard work, and this was a card, is how the staff wanted it, that we passed this out initially to all team members to say, here's what we agreed upon, and we also used this to make sure that we had float staff who are aware when they came to our unit, and travelers when we had traveler nurses on the unit during this time too. And so all staff agreed, hey, this is what we're going to do. This is the basic care that we're going to provide to our patients, and we really were all excited to brush our patients' teeth. We did initially complete some documentation audits, and that was really to make sure that staff were understanding the importance of documenting it, and also making sure that supplies were actually in the room. So if oral care was documented, we would make sure that supplies were in the patient's room, and we would ask the patients if somebody brushed their teeth, just to validate that it actually was occurring. So we looked at a couple different things. First was oral care supplies at the bedside. And in our patient population where the majority can do their own ADLs or need minimum assistance, a toothbrush and a toothpaste tube was what we considered the minimum for that. And so after our education, we stayed 100% compliant with that. And it's something still that is checked on the unit. And so here are some examples of newsletters, highlights that we sent out to all staff to recognize for staff members participating in completing oral care. This unit has about 70% RNs and about 30% unlicensed assisted personnel, and so we knew that it was really important to highlight both and ensure that all of the team members understood the importance of it. And so one of my proudest moments, a while into this work, it was probably 6 to 8 months after we had really started brushing our patients' teeth, is we had a float support staff member during safety huddle. When I asked if there was any questions, she asked if this was the unit that brushes their patients' teeth, and it made me so proud that we were known for that. It also worried me a little bit that that's what we were known for. It seems like such a simple thing to do every day, and so that was really an additional call to action that we have to really work to spread this work to make sure that you know, all staff understand the importance of such a simple task and how much it can prevent mortality in our patients. So this was our data for the nosocomial infection markers, which is what we used at the time to measure non-ventilator associated pneumonia. So in 2017, we had 1. We didn't have any in 2018. We did have 2 last year in 2019. And so the keys to success for this were really having a partnership between our RNs and our unlicensed assistive personnel, having each staff member take individual ownership for this, and we really continued to share evidence with the team. So even today, as articles come back out, and as the Wall Street Journal article came out, we print those for staff to have. We push them out and really still continue to spark that conversation. And we also worked really hard to make sure we were keeping the unit standards embedded in the culture. So with float staff, new team members, travelers, it was always something that we could count on any team member completing on our patients. And that is our references and citation. And I am going to turn it back over to the next presenter.
Thank you very much, Casey. That was excellent, and I appreciate your content and your very pragmatic approach to getting patients to brush their teeth and nurses leading the charge. Now I'll ask that Judy click share on your screen and then identify your slides, and we'll see how this transition works. If there are any questions for Casey, I did ask that you post those in the chat, and we'll come back to those on the end. There we go. Judy, we're seeing your list and not. We're seeing, go click stop share and share again, and make sure that you click your PowerPoint.
I am having a hard time seeing it. I think it has, I'm hitting share and it did not stop share. All right, share screen.
Share and then click your PowerPoint that you have in front of you, the beginning of your PowerPoint.
It's not doing it for me again.
Okay, I'll just pull up, I have your slides here, and I will pull them up. Just give it a second for the transition here. There we go.
All right.
You just tell me when you want me to
Right, yeah, just go ahead and I'll tell you when I want to change the slides. Thank you, Becky.
Yes.
So last winter, I decided with Becky's prodding to reach out to one of the nursing homes that's close to Clark, because we know that every second counts in sepsis, and what we were seeing is a lot of times the patients would come in from the nursing homes, and when they get here, it would be so late in their recognition that it was really hard to adequately and quickly treat them and get them turned around. So I reached out to one of the nursing homes, and how I chose, you can change the slide, Becky. How I chose the nursing home was, there's one that's right across from our parking lot. One of the hospitalists here is the medical director there, and I have a very good relationship with him. And so I approached him about it, and he said that he would support me in this. He'd seen the work we'd done here at Clark with sepsis, and so he was on board with it. So then I reached out to the director of nursing at Hillcrest, is the nursing home we worked with. That's one of the American Senior Communities facilities. So the first time I went over, I met with the director of nursing, and then we pulled together a bigger meeting. We met with the director of nursing, the staff coordinator, the infection prevention nurse there, and the nurse practitioner. And that nurse practitioner I saw very early was one of the most important persons to work with, because if I had her buy-in on it and worked on what she thought was missing and needed improvement, it was really I was going to have her support. One of the things I figured out very soon was I really needed to listen to them. I know nothing about nursing homes or long-term care, and I didn't want to go in and pretend that I knew it, and because that was going to turn everybody off. And they really helped with it. The NP was fantastic with it. But one of the things, too, that I picked up really quick, this was going to be bigger than I thought it was. My thought was I'm going to go in and really emphasize stop and watch with them, but it really was a whole lot more than that. Next slide, please, Becky. So what we ended up and did was, and there were so many parts to developing the successful sepsis bundle there. The first thing, again, was that needs assessment. And, again, this was much bigger than I thought it was going to be. I thought, again, I'd be going and talking a lot about stop and watch, and that was essential in it. But what I found out from listening to the nurse practitioner was that the nurses really needed to be taught about assessment also. So it was extensive teaching that had to happen with them. Of course, we had to talk about prevention of sepsis, prevention of infection, and what we saw most in the nursing homes. And again, there were some things that the nurse practitioner specifically wanted geared to that nursing home and the patients that she saw every day. We had to develop the sepsis screening tool, and again, what worked best for that facility. And again, I pulled in some of the things that the nurse practitioner was really in tune to. We had to have an algorithm. Once you recognize sepsis and you do the stop and watch, where do you go from there? So that algorithm for early recognition, escalation, and treatment. Teaching the staff was really a challenge because you have everyone in the nursing home that we were reaching out to. It wasn't just the RNs and the LPNs, wasn't just the nursing assistants too. We had the dietary people, we had environmental services. Anyone who walked inside a patient's room, we educated. So trying to find a way to reach such a wide variety of staff was certainly a challenge. Education of patient and families, they really wanted to hold off on that until all the staff was educated, so that was delayed. And then our outcome measurements, we're still looking at getting those, and I'll talk about that a little bit later. So you can change the slide, Becky. So, how do you get their attention? And, you can talk about the data, the survival statistics, all of those kind of things, but really, some of the statistics that we talked about, elderly make up 1/5 of the population, but 2/3 of the patients admitted to the hospital with sepsis are in that elderly population. And it's that elderly population that really has the highest mortality rate. So we really tried to make them understand how susceptible their population is. And as Becky alluded to earlier, you know, the immune system in these people, the decreased mobility, all the comorbidities they have make it so much more vital that we catch sepsis early in this group of people. If you're 65 years or older, you're 5 times more likely to develop sepsis than younger adults, and if you live in a nursing home, you're 7 times more likely to develop sepsis. So I really wanted them to understand that they have the most susceptible group of people at their fingertips every day. Next slide, please, Becky. But we all get tired of statistics. So one of the things I wanted to try to make it personal with them. And so we talked about, do you know anyone who's had sepsis? And pretty much in every class, someone knew 1 or 2 people who had sepsis, people who had died from sepsis. Right when I was giving this talk, we had a physician locally whose young son had died of the flu. And a lot of the people in the community knew that, and this really impacted them. And to tell and stress that fact again, that yet when you die of an infection, you're dying of sepsis. And I think there's a disconnect in our society with that, obviously, since only 65% know about sepsis. But what I really wanted to emphasize to them, too, is these patients, they're with them day in and day night. They are at the bedside. They are the ones that are going to pick up the early signs of sepsis in these patients. They're the ones who are going to impact the outcome for their patients. When we talk about outcome with sepsis, we are talking about survival. Next slide, please. So Stop and Watch was very much a big part of teaching this. They had taught Stop and Watch in orientation with people, but with all the stuff, but it really kind of fallen off the grid and people were not paying attention to it. So when we start talking about education, next slide please, Becky, we talked about the most common sites of infection, and again, Becky's put some of that data up there, and we really talked about prevention of infection. With pulmonary, we did talk about oral care and cleaning dentures. You know, with the catheters, we went into specifics and things with CAUTI. We talked about skin, all of these things that they needed to be aware of in trying to prevent. And again, the NP, the nurse practitioner there, had a lot of specifics that she wanted addressed with these areas, and that's how we made it specific to this facility. Next slide, please. And again, we cannot talk about sepsis and prevention without talking about hand washing. Next slide, please, Becky. So in order to treat sepsis, you first must recognize it. Next slide. And so Stop and Watch, and we really went through this and talked about the difference knowing your patients make. This staff, I mean, when you're in a nursing home and you're there for a while, you know these patients. They're long-term residents. Even in the rehab, it's people they get to know. And the little bit of change that they see in those patients, acting a little bit differently, how they talk or communicate less, needing more help, all of the things that are listed here in Stop and Watch, and that's what we really, really emphasize. And I told the story of about a patient that I've been following here in the hospital for several days who was in with sepsis. And this little lady, the only thing that she said was, "Mommy, mommy, mommy." Well, she ended up and had surgery, went up to critical care, and the next day when I'm up there rounding, doing treatment rounds, the staff says all she does is says, "Mommy." I said, "I know this lady," and I went in the room, and her mommy was totally different. I mean, this lady was much more lethargic, much more obtunded, it was a very different tone of voice. So I used this story with the staff there to say, you know, this is how you pick up the subtle changes in your patients because you know them. And it's those subtle changes that are going to trigger the Stop and Watch and trigger the whole escalation process. Next slide, please. So nursing assessment was something that I was not thinking I was going to have to teach, but it became very important from listening to the nurse practitioner and the calls that they were getting from the staff about a patient. So when I taught about nursing assessment, I really taught about nursing assessment, taking a stethoscope in, talked about the change in mental status, talked about that vital signs needed to be checked, that they needed to know about what their O2 stats were, any changes from their vital signs and what were their usual vital signs. Have they had any recent falls? And very importantly was, what is their advanced directive? Next slide, please. So then we had to, after we taught assessment and that, we had to come and we had to teach them the sepsis screening criteria. And this was from a lot of the data and what I read out there. As we know, elderly people do not have the same presentation that the adult population does. And so we developed the sepsis screening for them, the suspected infections, and used this to teach. Next slide, please. It was a paper screening tool. So once that they were handed a stop and watch with that chain, it could be from respiratory therapy, it could be from physical therapy, it could be from the nursing assistant, it could be from the dietitian. Once they got a stop and watch, then they took the tool and went in and did the screen and the assessment on the patient. Next slide, please. So this was the algorithm that we developed. We had to go back and kind of tweak it a couple times, but bottom line is that nurse receives the stop and watch. Once the nurse, the LPN or the RN receives that stop and watch that there's a change in that patient, they went in and did a complete assessment on that patient with a stethoscope, took vital signs, did the O2 stats on the patient, and did the screen on them. And very important, if they were screened negative, then they still had vital signs taken every 8 hours for 24 hours. And that was something that specifically that the NP wanted done because she felt, and we felt, that these patients need to be watched closer. If that screen was positive, then they put a call out to the provider, but they used the SBAR that was in their electronic medical record and used that means of communicating to make sure that they had everything there, all the information that they needed to share with that healthcare provider. They reviewed those advanced directives with them so they knew exactly where things were coming from and what those goals of care were from the family. And then from there they made the decision whether or not they were going to keep that patient in the facility or transfer him to the hospital. Next slide, please, Becky. So what we're hearing back, and it's been very nice, the positive reinforcement from the ED docs. And we still meet monthly, our sepsis committee, every month, and what we're getting back from the ED docs is, oh my gosh, what a difference this is making in that early recognition of sepsis and these patients being brought in a timely manner so that they can get the fluids, the antibiotics, and we have a greater chance of a positive outcome with this population. That's it, Becky. Hello?
Judy? Hello,
yes.
Judy, if you would just mention also the comment from the nurse practitioner at the facility.
Yes, I will. Sorry, thank you. The nurse practitioner has said that what she's seeing is she is getting these patients when they're calling her, that they are able to communicate with her. And this is also one of the things that I heard back from the physician was that they were getting a call that would say there's a change in the patient, but there were no vital signs taken, there was no patient assessments given. And now she says that what she's seeing is when they get a call, they're able to tell them what they need to know about the patient so that they know how to intervene and what steps to take. So that was good news also.
Thank you, Judy. That was just an excellent presentation of a conversation that we'd had through one of the work groups for the South Central Patient Safety Coalition and through the September Sepsis Awareness Month, the call out to please work with your extended care facilities. I will say that over time we've included extended care facilities in our educational programs that we've had. And both of these areas that we talked about today, oral hygiene as well as working with our extended care facilities for better care for sepsis patients, are keys to reducing mortality across the state and increasing sepsis awareness. We have to look at how our patients navigate across the continuum, and I thank both of these presenters for their content and their outreach and improvements, both on the research end as well as on the performance improvement side and extended care facility, and hope that some of you on the phone here can take some of this and run with it. We know that CMS is focused greatly on the 30-day post-acute care period with their financial Medicare spending per beneficiary. And what Judy was talking about, the stories, so that's going to continue, but now the focus is going to be on our extended care facility and how we can work together for good continuity of care across the continuum. That's going to only get increased in magnification, and we have an opportunity to work just like Judy did with our primary and referring extended care facilities. So the call to action for today's meeting, Casey, do we have any questions in the chat room? Okay, I'm going to open up in a moment for what are your action items that you hear that were particularly impactful to you based on these webinars that we've done. But the call to action for today is make sure you're implementing oral hygiene standards for inpatients in your facilities. This is basic nursing that we've gotten away from, and it can make a huge difference on reducing pneumonias and therefore reducing length of stays and for our patients, as well as getting them more likely to go home at the end of their admission. We are asking you to provide community outreach on sepsis education and prevention, including your extended care facilities. This is a partnership that you can tell Judy benefited from greatly, and it will improve care for all of our patients, and especially us as we get older. When she mentioned the identification of sepsis in the 55 and older population, we got a little close to home there. So let's get this improved before all the baby boomers get there. So these are the two calls to action for you. I want to mention that from the questionnaire that we sent out, the sepsis survey, has your facility provided outreach to education to the community regarding sepsis? We got a total of 51 yes responses, so about 50%, which I think is pretty good. However, really, it's our role to work with our community, and community health is something that's part of our mission at Indiana Hospital Association, and I know that hospitals have that as their mission as well. And we ask that you include sepsis education as your community outreach for improving health care to your communities. So from this, I would like to open it up. If anybody has questions for Casey or for Judy, we will unmute all the lines here in a moment. But what are your ideas for action from these webinars that we've done? Today's or any of the previous ones, you can type it in the chat room and we'll call it out as we go. Or if you would like to share with us anything that you are going to implement based on the webinars that we've provided, or your current processes of improvement for sepsis care. And the lines are all open. Please mute your own line if you're not going to speak, though, so we don't hear everything going on in the room there. What are your ideas for action from these webinars? What spoke to you? Are there a question in the chat room. Are there samples of community outreach available we can use at our facility? So in the 2019 Sepsis Toolkit that IHA posted, we referenced the Sepsis 911 teaching module that is provided by Sepsis Alliance. That has a teaching video, it has pre and post questions, and specific content that you can use. If you use the hyperlink in the Sepsis Toolkit for Sepsis 911, that is a total module for community education. And I think what Judy mentioned, that when you start off the conversation by asking, has anyone in this room been impacted by sepsis or had someone who died of sepsis or severe infection? That is an attention-getting step. But the Sepsis 911 video is a short video YouTube about a survivor of sepsis and her getting the right care at the right time. So that's where the sample community outreach education. Any other questions or comments? Oral care is a great project we can reinforce. Thank you. Yes, excellent. Thank you. BDXM 15, whoever you may be.
This is Casey Hutchins. I'm in the room here with Becky at IHA. Something I want to remind everybody, the sepsis page on our IHA website, on the Patient Safety Center page. Also, you can go to survivesepsis.com is another way to reach that page. that is where you can still access the 2019 toolkit that is still available on that page, as well as all of these previous webinars, the slides and the recordings are available there. And probably in the next 24 hours, today's presentation and slides will also be posted there. So that's a great place to get all of your sepsis resources. We post everything to that page.
And if you have trouble navigating anything, just email me.
Yeah.
Chris Newkirk from Columbus, who's been one of our leaders, we're working with our local ECFs to prevent readmissions as well, making sure that antimicrobial stewardship addressed and making sure hydration is adequate, not sending the patient out without making sure they have not had any extra fluids removed, perhaps from fluid bolus, and also making sure oral hydration is adequate. Chris, I want to also mention that Dr. Kaiser mentioned in his podcast on sepsis bundle compliance to make sure that the patient is euvolemic at discharge so you're not sending them home in heart failure with extra fluids on board. And I think that in the transition from IV to PO intake, we need to make sure that the patients are taking an adequate amount of fluids, PO, if that is their case, using their hydrating that we talked about earlier. So thank you, Chris. From T. Smith 73, is there anything specific being done for education, prevention in the ambulatory clinics? So from the sepsis task force, there is a subgroup on primary care. And so I think that what's going to happen is the recommendations from the sepsis task force will go to this particular group of ambulatory clinics and primary care offices. We have worked with, through QSource and Purdue Healthcare Advisors and us working as a triad, we have tried to outreach through Purdue Healthcare Advisors, who has had a grant, but it's an interim right now, just like the HIN is going to be an interim starting in March. So there are a couple places in process to work on getting content for ambulatory care clinics cranked out there. Comment from one, and I hope that addresses your question, T. Smith. That's in process. I also heard that loud and clear through, not loud and clear, subtly through the sepsis task force, but what this will be points of action for our state task force. Comment, we will reintroduce oral care at our facilities. It is a highly cost-effective intervention, yes. Also talk to your dentist about the need for oral care and pneumonia prevention, because they say you're preventing gingivitis, and it's much greater than that. Our older adults need to know that they can prevent pneumonia by doing oral hygiene. Glad to answer your question. Other ideas for actions from these webinars that we've provided? I know you're just burning to get out there and start your work. Any other things for the chat? Are there any predictive analytic tools for early detection of sepsis? Predictive analytic tools for early detection of sepsis. So what I know from the survey, and this is anecdotal as I haven't done total data analysis, anybody knows me, know I want to do total data analysis before I state anything. However, what I know is that many of the hospitals are using predictive analytics in their electronic medical records to do sepsis screening. And it's with varying degrees of success, but I will, what it is, it's validating what's going on with the primary electronic medical record in their alerts, and then it still takes some clinical judgment going on. So the predictive analytic tools, there's nothing being published that I've seen with the electronic medical records oftentimes using the modified early warning system as well as the Sears criteria to identify patients. And Chris Newkirk, if you have any comments on this predictive analytic tools out of the electronic medical record, you feel free to speak up here, because I know that you did a lot of validation at Columbus Regional for your first EMR and then the second EMR that you just re-implemented and changed EMRs. I know you did a lot of validation for that.
Yeah, this is Chris. We did. We actually built a sepsis alerting system within our Cerner system, and then we recently in July switched to Epic after, of course, we perfected our Cerner. So we're kind of feeling like we're back to ground zero as we try to perfect our Epic system. But we do use predictive analytics tools and use those early warning signs for sepsis. And it is based on source criteria and organ dysfunction parameters we have set within our EMR.
The generalized recommendation that we've seen is sepsis screening every shift and with acute changes in condition, which can be done manually, and that's an educational piece that the nurses need to be aware of. It is new education. Those who've been in practice for a while do not know about sepsis. So teaching them how to screen using the Sears criteria and integrating that with your physician, and the SBAR piece that Judy talked about, using SBAR as a communication tool with your physicians allows them to use a platform with which the information is clearly repetitive every call that they get in SBAR form, so you can just tease out what's different so it's not an overwhelming or disorganized report. So the SBAR, along with teaching them to do screening, but also the predictive analytics that are available in the EMRs. Other comments? I think we're at the top of the hour now. Anything else? All right. I thank you all very much for your chat and for your attention on this webinar. We had about 66 people on, and thank you very much to Judy Brome and Casey Ruan for their presentations. And Judy being the manager of the nurse residency program, and their emails are there, as well as Casey's director of clinical ops for the surgery unit at IU Health University, and their emails are there should you need them, or you can email me with any questions and we'll get back to you as quickly as I can. Thank you so much for your attention, and look forward to working with you again on sepsis. Thank you, CJ.